Good. Thank you, everybody. Thank you to today's session of ECHO. I wish to welcome you all. G-ECHO is hosted by the Gastro Foundation in association with Polyposis of the University of New Mexico. These G-ECHO is meant for G-ECHO fellows and is run every Monday from 6 o'clock, alternately between the surgeons and the physicians in gastroenterology. The chat will be open for questions afterwards. And with that, I wish to introduce to us Dr. Qubekile to carry on with the polyposis syndromes. I think the importance is that some of them can lead to cancer. So thank you very much. Then with that, I want to give the stage to Dr. Qubekile. Yonela, the stage is yours.
Good evening, everyone. Today I'll be talking about polyposis syndromes. Cheryl, can you please share the slides?
Will do.
From the beginning, thanks.
Yes, one moment. Oh, it's just give me one moment. It's giving me a bit of trouble. Sure. Close this slide. Okay, we're good to go.
All right, next slide. Just before we talk on the topic, I just wanted to just do a quick introduction in terms of what is a polyp. So a polyp is any mass protruding into the lumen of a hollow viscous. So it can be classified according to the macroscopic appearance, which can be sessile, which is flat, arising directly from the mucosal layer, or pendiculated, which is extending from the mucosa through a fibrovascular stalk. Or it can be classified in terms of histological classification, which can be neoplastic or non-neoplastic. In terms of the non-neoplastic, these are divided into hyperplastic, adenomatous, or inflammatory. But the neoplastic are the more important ones in terms of our topics because they harbor a malignant potential. And we know that in terms of colorectal cancer, it can evolve from adenomatous to polyps. And the sequence of events leading to this transformation is called the adenoma to carcinoma sequence. Next slide. So just a reminder in terms of polyp classification, we all know the slide. I just thought, let me just put it in here, which is the Paris classification, which can be divided into the protruded lesions, the flat elevated lesions, or the flat lesions. I don't think I need to go into much detail because I think most of us are familiar with the classification. Next slide. So polyposis is a systemic process that promotes the development of multiple gastrointestinal polyps. Hereditary gastrointestinal polyposis syndromes account for approximately 1% of all cases of colorectal cancers. So this is why early detection and accurate classification of these syndromes are essential to initiate surveillance programs for early detection of cancer or malignancy. Next slide. So the classification of GI polyposis syndromes can be classified according to whether it's a histological classification, whether it's adenomatous polyposis syndromes, and these are divided into familial, which is the prototypical common one. I'll go into all these variants, all these types throughout the presentation. Familial adenomatous polyposis, variants of familial adenomatous polyposis, the MYH-associated polyposis syndromes, and then there's the serrated polyposis syndromes. And then the adenomatous polyposis syndrome, which contains the Peutz-Jeghers syndrome, juvenile polyposis, and the others which are mentioned here. And then the rare adenomatous polyposis syndrome, which we'll talk more in detail about hereditary mixed polyposis syndrome. And then the non-inherited polyposis syndrome, which we'll touch on a bit later in the presentation. Next slide. So familial adenomatous polyposis is one of the common prototypical hereditary polyposis syndromes amongst the polyposis syndromes. It's inherited as an autosomal dominant disease, and its prevalence is that of 1 in 5,000 to 7,500. But in terms of in South Africa, the incidence, we don't really have a polyposis registry when I looked in the literature. So it's difficult to determine in terms of what the prevalence in South Africa is. There's a mutation of the APC gene, which is located on chromosome 5. The onset is usually early during childhood or adolescence, and the number and size of the polyps tend to increase with age. And the median age of diagnosis of colorectal cancer in these patients is at age around 42 years of age. Next slide. It tends to present with hematochezia, diarrhea, and abdominal pain, especially if there's a high polyp burden or the patient has developed cancer. Diagnosis by sigmoidoscopy, is by sigmoidoscopy, but a full colonoscopy is preferred to exclude colon cancer. At diagnosis, there's usually a presence of more than 100 polyps, and normally you also require histological confirmation, but the definitive diagnosis is with APC gene testing, which also distinguishes it from other adenomatous polyposis syndrome. Studies also suggest a 10-year period between the appearance of the polyps and the development of cancer, but it is responsible for less than 1% of all colorectal cancer cases. Next slide. The average onset for familial adenomatous polyposis for diagnosis in one study was about age 36, with the diagnosis of cancer, which was about 39 years of age. About 90% of these cases had been diagnosed by age of 50 years, and early screening for malignancy found that 50% of these patients of FAP gene carriers had a polyps at sigmoidoscopy by age 15 years of age. But it is important to note that between 30 to 40% of cases occur in the absence of a positive family history. Next slide. So on colonoscopy, you'll tend to find that there's about 100 to 1,000 of adenomatous polyps in the large intestine. And this begins with small polyps, and the number increases progressively until the colon becomes carpeted with adenoma, as you can see on the picture as demonstrated. And these usually develop by the age of approximately about 10 to 12 years of age. So some of the upper GI findings that you can find in FAP are gastric polyps, which occur in about 30% to 100% of the patients. These tend to be non-neoplastic fundic gland polyps. They're about 1 to 5 millimeter sessile polyps. And usually dysplasia in FAP due to fundic gland polyposis is associated with larger polyp size, also an increased severity of duodenal polyposis, and also antral gastritis. But dysplasia is inversely associated with the use of acid suppressive therapy and the presence of H. pylori. Gastric adenomas occur in about, sorry, I'm still on the last previous slide. Gastric adenomas occur in about 5%, and these are usually in the antrum. Duodenal adenomas occur in about 60 to 90% of FAP patients, and mainly are periampulary, with the 4 to 12% lifetime incidence of duodenal cancer. Okay, next slide. So if patients do have duodenal adenomas, the duodenal adenoma burden is scored using the Spiegelman staging system. So this staging system basically looks at the adenoma size, the number, the histology, and also dysplasia. And this is used to determine the appropriate timing for upper endoscopy. So patients, in terms of the staging, they can score from a range of about 0 to 12. And normally this helps in terms of appropriate timing for upper endoscopy. And then in terms of considering whether you need surgery, especially when you're considering stage 4 scoring. Next slide. In terms of some of the extra intestinal manifestations of FEP, up to 75% have congenital hypertrophy of the retinal pigmented epithelium, and this is detected by ophthalmoscopy. And most of the cases, if you do find bilateral congenital hypertrophy of the retinal pigmented epithelium, these patients tend to have, there's a likelihood that they have the gene, the positive APC gene. They can also have osteomas, which are benign bone tumors in the skull, mandible, and long bones. And this is also associated with a variant of FAP, which is Gardner syndrome. They can also have supernumerary teeth, impacted teeth, mandibular cysts, and they also can have Desmond tumors, which occur in about 10 to 15% of patients with FEP. And this is the second cause of death after colorectal cancer. And these Desmond tumors are locally invasive tumors of the retroperitoneum and abdominal wall. They tend to appear mostly after abdominal surgery, but they can appear spontaneously as well. And they tend to be difficult to treat. And they can also have thyroid or adrenal tumors, and they can also have medulloblastoma. And I've put the Turcot syndrome here, which is also a variant of familial adenomatous polyposis. Here, these patients primarily have, they have primary tumors of the CNS, and there's also mutation of the APC gene, and they present with the, most of the time, they tend to present first with medulloblastomas. This precedes the diagnosis of polyps. But with the Turcot syndrome, there's also another gene mutation, which is the DNA MMR gene mutation. And these patients tend to have glioblastomas rather than medulloblastomas. And this germline mutation, which is the DNA MMR gene, is associated with the Lynch syndrome. Next slide. So in terms of diagnosis is confirmed by the appearance of the multiple colorectal polyps and sending the polyps for histological examination. Genetic testing can detect approximately about 80% of the APC mutation. Screening of first-degree relatives is advised. If genetic testing is not performed on first-degree relatives, screening by sigmoidoscopy at age 12 is recommended, then annually until the age of 35. If by age 35 they have not been diagnosed, then sigmoidoscopy can be done every 3 years. But once adenomas are identified, an annual colonoscopy until prophylactic colectomy. And also upper endoscopy is performed every 1 to 3 years. Once you find adenoma, you can use the Spiegelman classification as described in the previous slides to guide in terms of how you're going to follow and screen the patients further. Next slide. So in terms of treatment, there's been, in terms of, there's a study that looked at ascorbic acid for its antioxidant properties in patients who had gone, who had undergone subtotal colectomy. And it did have some modest effect, which was observed, but the data was neither here nor there. So there's no recommendation in terms of using ascorbic acid. In another study, which looked at 58 patients which were treated with ascorbic acid, vitamin E, and supplemental fiber, there was modest effect, which was seen after 2 years of therapy. Then there's non-steroidal anti-inflammatory NSAIDs, which they looked at Sulindac, which did show a reduction in the number and size of colorectal adenomas. But this does not protect them from developing colorectal cancer. And the drug's effect is reversible upon discontinuation. So you need to continue with it throughout. And then there was another study which looked at celecoxib, which is a selective COX-2 inhibitor. It did show reduction in number and size of rectal adenomas. And then the CAP1 study, Also, which is a colorectal adenoma carcinoma prevention study, which looked at aspirin 600 milligrams per day, which did reveal a lower polyp count and size, but they didn't look at a lower dose in terms of aspirin. There's no studies which looked at a lower dose of aspirin. Okay, next slide. The definitive treatment is surgery. Prophylactic surgery is directed at removal of all the affected colonic and rectal mucosa. And the recommendation in terms of timing for surgery is soon enough to prevent malignancy, but late enough to reach physical and psychological adulthood, especially if the patient is diagnosed earlier on. So the three surgical approaches which I saw that they talked about in terms of treatment was total abdominal colectomy with ileorectal anastomosis, or total proctal colectomy with formation of an ileal pouch and ileal anastomosis, and also total proctal colectomy with end ileostomy. I thought I didn't go into which one is better and whatnot. So next slide. And then the other type of polyposis syndrome in the adenomatous type is the MYH-associated polyposis syndrome, which is a rare autosomal recessive adenomatous polyposis syndrome. Approximately about 1 to 2% of the population are carriers of mutation of the MYH gene. The median age of diagnosis is about 48 years. And polyps typically are small tubular or tubulovillous adenomas or hyperplastic polyps. And the risk of colorectal cancer is about 80% by the age of 70 years in untreated patients. These patients tend to develop about 10 to hundreds of colorectal polyps, which are detected in adulthood. Mostly these polyps are right-sided. Upper GI polyps may occur, but are much less common compared to FAP. Next slide. The European Society of Medical Oncology recommends for carriers of HY polyposis for colonoscopy every 2 years, starting at age 18 to 20 years, and upper scope starting between upper endoscopy starting at between the ages of 25 to 30 years. Colonoscopy annually once adenomas are detected, and every 3 years, 3 to 5 years if no polyps are detected. Siblings should be genetically tested and counseled as well. Genetic testing can be complicated by the phenotypic overlap of the MYH polyposis syndrome with the FAP. Polypectomy can be done or performed, but most of the time, eventually, these patients will require a colectomy as the polyps become too much to control via endoscopic treatment. Next slide. So just a summary in terms of the adenomatous polyposis syndrome. So we talked about the classical FAP, adenomatous polyposis syndrome, and then there's the attenuated FAP, which I didn't go into it, which is basically these patients, it's a variant of adenomatous polyposis syndrome. These patients have fewer polyps, which are less than 100, and these polyps are flat rather than polypoid, and the colorectal cancer tends to arise later, at a later age in the 6th or 7th decade, and surveillance in these patients is every 1 to 2 years, starting at the age of 25. Okay, and then next slide. Then the next condition is Peutz-Jeghers syndrome. This is a rare autosomal dominant syndrome with hematomatous polyps. There's a mutation on chromosome 19, and the gene name is STK11. The incidence is 1 per 200,000, and the average age of diagnosis is at between 23 and 26 years. Polyposis of this tends to affect the small intestines more, and then also the colon and stomach, and also the rectum. The common clinical presentation most of it is gastrointestinal bleeding or intestinal obstruction from intussusception. Next slide. These patients have a characteristic skin and bluish buccal mucosal pigmentation, which affects the lips, the hands, the feet, the genitalia, and the anus. And these tend to appear at birth, and by puberty, they become lighter, and most of the time by adulthood, they've faded off. The lifetime risk of cancer of any type in this patient is approximately 90%. So there's an increased risk for colorectal cancer, breast cancer, pancreatic cancer, gastric, ovarian, pulmonary, and cervical. And the cumulative risk of cancer is 20% at age 40 and at 76% at age 70. One study had shown. Next slide. And these images show the typical findings that you find on Peutz-Jeghers. As I said, these hyperpigmented lesions in the buccal mucosa, also on the face. Sometimes some people can mistake them for freckles. Okay, next slide. Diagnosis is through the clinical picture of GI adenomatous polyps in histology, and also characteristic cutaneous and the mucosal pigmentation is shown in the picture. The World Health Organization diagnostic criteria, especially if there's a family history, they say any number of polyps or characteristic mucocutaneous pigmentation. Genetic testing is also feasible in cases of a known family member. And screening colonoscopy for those that are suspected, if there's a known family member, with the colo, upper endoscopy, and small bowel follow-through beginning at age 20, and this is repeated at 2-year intervals. And surgery is reserved for symptoms such as obstruction. Okay. Next slide. I can't see the bottom of this slide. And then surveillance. So for these patients, because there's a high risk of multiple malignancy, surveillance is quite important. So you need a yearly history and physical examination, capsule endoscopy every 2 to 3 years, starting at age 10, then upper scope every 2 to 5 years, starting at age 20, colonoscopy every 2 to 5 years, starting between 25 and 30 years. MRI or endoscopic ultrasound of the pancreas annually, starting at age 13, breast exam and breast MRI starting at age 25, also with the mammography starting at age 13, and a pelvic exam, pap smear, transvaginal ultrasound, and a CA-125 every year between the age of, starting between the age of 25 to 30 years. Next slide. So the next one is juvenile polyposis syndrome. These are adenomatous polyps that lack smooth muscles. And this is an autosomal dominant disorder which develop hundreds of polyps in the colon and rectum. It tends to appear in childhood with an average age of diagnosis at about 9 years. The diagnosis is based on more than or equal to 5 juvenile polyps in the rectum or colon, or multiple juvenile polyps in the upper or lower GI, or any number of juvenile polyps, especially if there's a positive family history. The classical presentation is that of lower GI bleeding, bowel obstruction from large polyps, or intersusception. They may also develop a protein-losing enteropathy. Next slide. Screening for cancer in these patients should begin at age 15 years or earlier if patients are symptomatic. And this is repeated annually if there's polyps, or every 2 to 3 years if there's no polyps detected. These patients tend to also have congenital abnormalities. Up to 20% of the patients, they can have malrotation, hydrocephalus, cardiac lesions, Meckel's diverticulum, and mesenteric lymphangioma. And the lifetime risk of colorectal cancer is up to 39%, and that of gastric cancer is about 21%. There's also an increased risk of vaginal and pancreatic cancer. Screening for first-degree relatives is by colonoscopy and endoscopy every 1 to 3 years, starting at the age of 12. And then annually, once polyps are found, treatment tends to be prophylactic surgery. Next slide. And then the other is Cowden syndrome. This is also an autosomal dominant condition with hematomas. Most of the time, these polyps are asymptomatic in the colon and in the stomach. And these patients tend to have extraintestinal manifestations with a mucocutaneous lesion, thyroid adenomas, non-toxic goiter, and fibroadenomas, and fibrocystic disease of the breast. Previously, they've thought that the risk of colorectal cancer is quite low, but some studies show that the risk is up to 9%. There's a 10% increased risk of thyroid cancer and up to 50% risk of invasive carcinoma of the breast. Next slide. So they tend to present, these are the cutaneous findings that you find, which are called facial tricholeomas, that you tend to find in these patients with Cowden's polyposis. Next slide. So just a summary on, this is a table just showing a summary of the adenomatous polyposis syndrome, so which we went through in terms of Peutz-Jeghers syndrome, juvenile polyposis, Cowden syndrome. Then the others that's mentioned there, which I didn't go through, is also neurofibromatosis, which tends to affect the small intestine, stomach, and also the colon. And the patients tend to have neurofibromas, the polyps are neurofibromas. Okay, next slide. And then the other syndrome is that of serrated polyposis syndrome, which was formerly known as hyperplastic polyposis syndrome. This is sporadic and rare condition, and molecular and etiology and pattern of inheritance remains unknown. The diagnosis is based on colonoscopy with more than 5 histologically confirmed serrated polyps, which are proximal to the sigmoid, and 2 of them have to be more than 1 centimeter. Any number, or it can be any number of serrated polyps which are proximal to the sigmoid, and there's a history of a first-degree relative with serrated polyposis syndrome, or more than 20 serrated polyps which are scattered throughout the colon. Next slide. Once the diagnosis is made, an annual colonoscopy is warranted, and also serrated polyps of more than 5 millimeters should be removed. A screening colonoscopy for first-degree relatives starting at age 40, then at 5-year intervals if there's no polyps. If the polyp burden cannot be controlled by endoscopy, then surgery is indicated. Slide. And then in terms of the hereditary acquired, so there's also, hereditary mixed polyposis syndrome. So this one, there's multiple colorectal polyps of different histological types, so they can be adenomatous, hyperplastic, and hematomatous. It's an autosomal dominant disorder, and the age of onset is usually 23 years, with a median age of symptoms at about 40 years. But it does not fulfill any diagnostic criteria for other polyposis syndrome. It also lacks data on risk of colorectal cancer, but they do say it's higher than the general population. Next slide. So I found this case report of a clinical case of hereditary mixed polyposis syndrome, and this was in Cape Town. So this was, there was a 51-year-old woman who had a history of colectomy at the age of 11 years for polyps during childhood. So he had presented in 2002 with rectal bleeding, and her sigmoidoscopy showed rectal polyps, which are hyperplastic in histology. Initially, she was told that when they did the colectomy that she had familial adenomatous polyposis based on the histology. And then what had happened was when she had presented then in 2003, she was advised when they took the histology and everything, she was advised before the histology came back that maybe with that history, maybe her children also should be screened. So they were initially lost to follow up, and then one of her children presented, the 17-year-old had presented with lower GI bleeding with anemia. So then all the 3 children underwent sigmoidoscopy, and then the surveillance scope, the first child had a similar phenotype to the mother, and underwent colectomy and ileorectal anastomosis. And the specimens from that revealed more than 70 polyps with a combination of juvenile, hyperplastic, adenomatous, and inflammatory polyps. And then the second child had multiple hyperplastic polyps, and then the third child had a normal colon. So then, based on that initial diagnosis, which was made when she was 11, that they thought that this was familial, so adenomatous polyposis, they went back to check, was it really, or was this hereditary mixed polyposis syndrome? So when they went back and looked at the sections, they realized that it was actually hereditary, not FAP. So this is a case which is, I think, in Cape Town. This was in Cape Town. Next slide. So this basically is a summary of what I've some of the syndromes which I've spoken about. So if you look at them, the table shows the syndrome, the lifetime risk of percent of colorectal cancer, and or other malignancies, and screening recommendations. If you look at familial, you can see that the risk of colorectal cancer is near 100%. So I've gone through each one in terms of what screening you need. And as you can see, duodenal, gastric, thyroid, and also with the MYH-associated, you can see colorectal can go from 43 to 100%. And then Peutz-Jeghers, as you can see, also breast cancer is also quite high. But I went through all the screening recommendations for each. And basically also with the juvenile, the colon cancer risk is also quite high, 40 to 50%. Next slide. So these are just touching on the acquired polyposis syndrome. So this is Cronkite-Canada syndrome, which is an acquired non-familial disorder. It's a there's gastrointestinal polyposis in association with alopecia, cutaneous pigmentation, and oncolysis. They tend to onycholysis. They tend to present with diarrhea and vomiting, and also protein losing enteropathy may also occur. There's occasional malignant degeneration of polyps, which may occur. Surgery is also here reserved for complications such as obstruction. Next slide. And then the other non-inherited polyposis syndrome is lymphomatous polyposis, which can be seen in Hodgkin's and in variants of Hodgkin's and non-Hodgkin's lymphomas. And these can present as multiple lymphomatous polyps of the GI tract. And then there's also nodular lymphoid hyperplasia, which is a rare lymphoproliferative disease and tends to be asymptomatic. It's seen in healthy children. It can also be seen in the terminal ileum in Gardner syndrome, also in immunodeficiency syndromes like combined variable immunodeficiency, and also in IgA deficiency. Next slide. So in conclusion, most colorectal cancer cases are sporadic, with the hereditary factors contributing to approximately 35% of colorectal cases, and less than 5% of colorectal cancer is associated with the known genetic syndrome. Although each of the above syndrome is rare, it is important to know characteristics and know the cancer risks. And this information is also valuable for treatment and in terms of surveillance plans. Okay, thank you. That's the end of my presentation. I welcome any comments, additions, and questions.
All right. Yonela. Thank you very much for that detailed overview of these polyposis syndromes. You didn't mention anything related to ulcerative colitis in terms of this dysplastic dysplasia-associated lesional mass, but don't worry about it. It's just related to that. They can be precancerous as well. They have to be treated with care. All right, but thank you very much. This is a very difficult subject for me, but I think it lies within the realms of surgeons and oncologists, actually, because if they are being taken care of, people can prevent cancer ultimately. And I think you have mentioned that they are a rare cause of cancer anyway. So for us as a physician, because it's a long list of things which I don't know how you will remember those things, but I think for a physician, just to remember that remember three things. I think it's very important you can remember just three things. There are proto-oncogenes. These are the genes that code for cancer, for formation of cancer. They promote other genes to become cancerous through very complicated mechanisms of signal transduction. It's quite complicated, but just know they can do that. It's proto-oncogenes. And are those genes which are responsible for suppression of tumor development. They're called tumor suppressor genes. All right. Then there are also some genes that code for the repair of damaged genes. So it's just three things I'm mentioning: proto-oncogenes, tumor suppressor genes, and the genes that code for the repair of the damaged genes. So if any one of those doesn't happen, then cancers will occur. So these proto-oncogenes or oncogenes, they do exist. They have got names. You can ask the geneticist to look for if you have a condition which you think this would be genetic, because it looks like many systems are affected with this abnormality. Then you can think it's genetic. So it's either autosomal dominant or recessive, but that will come later. Right. So then obviously if you get the report from the geneticist, they tell you this fits in with a certain certain gene or oncogene, or whether lack of a tumor suppressor gene, then they can also even advise you where to look for other conditions. And then, fortunately or unfortunately, if they fall within the realms of other disciplines, they also have a way of how they can screen these for whatever cancers in that organ. Because if it's cancer of the mama or the breast, they know what the protocol, right? As an example. Yeah, so I was just to mention, yeah, it's listing things is always difficult, but APCs and your SMAD4s and your STK, that's STK, serine kinase. Those are tumor suppressor genes, which one would know, but there'll be other types of like oncogenes, like KRAS is an oncogene, that one. And the BRAF is also an oncogene, as an example. These are quite difficult. While we're there, I'll say that the hyperplastic polyps, I think, lately, they are the subset of the serrated polyps. I think the bigger part, the mother would be the serrated polyps, and then the hyperplastic come under there. The hyperplastic polyps, it just happens that in them, there has not been any abnormalities in terms of acquisition of the BRAF mutations or that methylations of the MLH1. That did not happen, so they remain nicely hyperplastic. But otherwise, if that happened, those serrated adenomas go straight to cancer, most. I think that's my contribution only for tonight. And yeah, I do not know if there's anything. Yeah, no, there's something else. This adenoma carcinoma sequence, I think I've touched on that. The FAP familial, that FAP, there's attenuated one, and that one that is florid. It depends on where the genetic mutations have happened along the chromosomes, basically. If the mutations have happened within the first 3 exons, then it runs an attenuated course. But if it happens distal to maybe exon 15, then you get a florid course. So that's why these are, it's FAP that is thought whether is it attenuated or that, but it depends on where along the chromosome, along the exons, the problems happened. So again, I emphasize that you should have a geneticist in your company or your multidisciplinary team if you want to understand these things, because otherwise, as to what happens, each discipline knows what to do. Well, that's all I can say, and then I'll leave it to the floor. But I just want to pass a warning. I'm technologically challenged today. I'm in Johannesburg, so I'm looking at you through a cell phone. My computer was saying it has to be a lot of things which I don't understand here. So, yeah, I'm not able to see who's on the line and who's having questions there. Not unless Cheryl can help us with that. Cheryl, are you able to help?
There is a question from Dr. Mazamu. Maybe he wants to unmute and ask his question.
Thank you very much. Not so much. Firstly, well done, Yoni and Dr. Ramanati. It is not so much a question as it is a comment. Just you kind of touched on the surgery or the prophylactic surgery for your FAP, and I suppose it will go for UC as well. I think it's something just to be borne in mind that you'll have a different surgery that you recommend to a female, who particularly that one who hasn't finished her family, versus a male, because there's a difference in fertility whether you use your ileal pouch anal anastomosis versus your ileostomy versus your ileorectal anastomosis. So that's just one thing to bear in mind. And then the other thing is, if you do still have rectum, then you need to continue surveilling that stump for adenomas and then and subsequent cancer. Thank you.
Thank you very much. I hope I'm fully audible. All right, Mzam, thank you very much. And I'm going to need a favor again. If there's no other question, I need a favor.
I'm listening.
That last part where I have to, well, obviously I have to thank the speakers and the participants. Everybody who's participated here. Ionela, you've done extremely well. I'm proud of you. So thank you very much. Like I said, I want to apologize again for being technologically challenged. I'm not at home. I'm not in the right place now. I'm in a foreign province. If you can do me a favor there, just to announce who's the next speaker for the next session on the 28th, please. I can't.
Okay, so the next talk is the 28th of November, and it's Dale Peterson with Reed Ali, who's going to be doing the chair, and his topic is IBS.
Thank you very much, Cheryl. Therefore, I wish to thank ECHO again for hosting us and helping us with this continuous education process. So with that, I wish everybody a good evening.
Good evening. Thank you so much.
Thank you for listening.
Thanks.